During this presentation, I'm going to discuss incarceration as a social determinant of health and its relationship to pregnancy. The United States has the second highest rate of incarcerated women internationally, second only to Thailand. While the U.S. has only 4% of the world's population of women, it is home to over 30% of the world's total population of incarcerated women. And around 4% of incarcerated women are pregnant at the time they are admitted to prison. Among incarcerated women, pregnancies are often unplanned and are complicated by lack of prenatal care, maternal trauma, poor nutrition, substance use, mental illness, chronic medical conditions, low socioeconomic status, and limited social support. Incarcerated women regularly experience a lack of reproductive rights and unsafe conditions for childbirth. These circumstances are exacerbated by Black, Native, and other women of color who are disproportionately represented in U.S. prisons. This disparity widens the health gap between white and Black women. The American College of Obstetrics and Gynecology standards for perinatal care in correctional settings include pregnancy testing, access to pregnancy counseling and abortion services, assessing and treating for substance abuse, HIV, and depression, appropriate vitamins and diet, delivery in a licensed hospital with facilities for high-risk pregnancies, and postpartum contraception. The National Women's Law Center completed an analysis of confinement in pregnancy, considering prenatal care, shackling policies, and family-based treatment alternatives in grading the states. 21 states received Ds or Fs, while a single state, Pennsylvania, received an A-. Only 30 states received passing grades, with most states lacking prenatal care policies regarding medical examinations, nutrition counseling, treatment for women with high-risk pregnancies, HIV screening, and pregnancy outcomes reporting. Testing early for pregnancy in correctional facilities is an important step in providing appropriate care to incarcerated women because it allows for timely initiation of prenatal care, counseling regarding pregnancy termination and adoption, and identification of women at risk for pregnancy-related complications, such as bleeding or ectopic pregnancy. Both the ACOG and National Commission on Correctional Health Care guidelines recommend offering pregnancy testing to women of childbearing age upon admission. Despite these recommendations, pregnancy testing is not routine in correctional settings. In a survey of 53 jails across the United States, only 38% reported performing pregnancy tests on all women entering their facilities. 45% described relying on inmate self-report of pregnancy status and then performing confirmation testing as needed. For pregnant inmates, labor and delivery may be additionally anxiety-provoking because of lack of control over the birthing experience, limited health education, absence of support from family or friends, mother-newborn separation, often within 24 hours of giving birth following delivery, and concern about infant placement. Additionally, high levels of stress in the perinatal period have been associated with maternal depression, preterm delivery, and low birth weights. Therefore, childbirth support and education are particularly important for incarcerated women who are already at higher risk for complicated pregnancies. In 2007, the United Nations Children's Fund, or UNICEF, noted that infants should not be separated from their mothers due to incarceration because of the child's best interest and a right to family life. If the mother is to be incarcerated, it was noted that the infant should be present in prison if possible. Only 4 nations routinely separate inmate mothers from their newborns, including the United States. Only a quarter of American states offer a mother-baby unit. The National Women's Law Center's analysis gave 38 states failing grades in the category of prison nurseries, noting that only 3 of 13 existing programs offered therapeutic services for both the child and the mother. There are only 13 states in the United States that offer mother-baby units. These 13 states are listed in the slide noted. They allow children to co-reside with their mothers until 12 or 18 months of age. Women must have no history of maltreating children and must not be incarcerated for a violent offense. Pregnant women in prison are consistently mistreated before, during, and after giving birth. In 2018, the First Step Act restricted the shackling of pregnant women in federal custody, but federal prisons hold only about 7% of incarcerated women in the U.S., and many states still allow the shackling of pregnant women and plan to continue the practice. Pregnant mothers in prison are often separated from their babies within 24 hours of giving birth, and this lack of critical contact between mother and child is a well-established contributor to negative health outcomes. Mothers are faced with greater likelihood of postpartum depression and an inability to breastfeed. State prisons across the country are developing programs to introduce enhanced prenatal care for women in prison. They provide doula support and childbirth education, offer prenatal and postpartum counseling, and promote maternal-infant bonding. Doula-assisted mothers benefit from positive health outcomes, such as reduced likelihood of infant low birth weight, reduced likelihood of complications, and increased likelihood of successful breastfeeding. Enhanced prenatal care in prison is also associated with lower rates of preterm delivery and C-sections. So how do we fix the problem? The Justice for Incarcerated Moms Act is one of 12 bills that are part of the Black Maternal Health Momnibus Act that was introduced into legislation in 2021. Specifically, the Justice for Incarcerated Moms Act would incentivize states and local prisons to prohibit the practice of shackling pregnant people, provide funding to establish programs that help to better assist pregnant and postpartum people in federal, state, and local prisons and jails. This would include access to doulas and other perinatal health workers, counseling, maternal-infant bonding, reentry assistance, and programs that prevent the incarceration of pregnant and postpartum people, study maternal mortality and morbidity within our prison system and the impact of racial and ethnic disparities, and finally, study how terminating Medicaid coverage will negatively impact the health of incarcerated pregnant people and mothers.